So, good morning, good evening, depending on where you're located in the world. Hold on just a second. Let me get my technology geared up here. We got a lot to cover today. I'll do a brief intro, short slide on the series of making stress your friend or rethinking stress. But we've also got Doctors Eric Goulder and Barbara McClatchie here. Dr. Goulder is a recovered cardiologist. We'll talk about what that means a little bit later. And Dr. McClatchie is a dentist. They practice together in a Bale-Donine style heart attack and stroke prevention program. They're going to do a little bit of the basics of what they practice, and then we'll do some Q&A. We'll talk about, as I said, what we mean by recovered cardiologists, what we mean by CIMT training, because I originally met Barb and Eric at a Bale-Donine meeting, but most recently have run into them because Eric's doing a lot of several of my patients CIMTs, and we'll talk for a minute about CIMT training. It's a major experience. But before we do, let's get through the intro for today. Yes, if you just happen to stumble into this channel is all about helping people understand what really causes the major causes of heart attack, of death and disability. That would be heart attack, stroke, things that have some underlying root causes like cardiovascular inflammation. And most often, cardiovascular inflammation caused by insulin resistance. As we talked to Barbara McClatchie today, you'll see that you see the mouth provides a window into this, and she has in her work, she has a lot to do with dealing with this issue. If you have more interest in what we do, we can't see everybody in the world, but we can help provide a lot of free content here where we're helping people understand what your doctor may not understand. The folks at Hopkins and several other places have done science which indicate your typical doc does not understand insulin resistance, not only how to manage it, even how to diagnose it. So here's some ways to help you learn. We have webinars, we have courses. Quite often you can get these things for free. Just keep your eyes open on the channel and get it when it's free, even if you have to pay for it. I don't think we've ever charged more than, $30, $40. In a couple of hours, you can learn more about these key drivers of death and disability than your doc knows. And the book itself is finally out. And as I've said before, I can say this as the prime author. Yes, it's a good book, but don't plan on sitting down and reading it in an evening. It's a large part of it's about as exciting as reading an encyclopedia. So don't go there expecting a lot of excitement. The intro, the first chapter, do sort of draw you in. They hook you in terms of talking about folks that have had heart attack, stroke, death after things like a stress test. And why does that happen? How does that happen? Then it gets pretty deep in terms of, and here's where the encyclopedia part comes up. If your cardiologist is using what we call a Framingham, then you can go in and look at the details on what that cardiologist is using, or your internist or your family practitioner. You can find the good and the bad. There are problems with the Framingham risk calculator, and we go into pretty excruciating detail on that. We also talk in depth about stress tests. In fact, the core of this book is what stress tests can't tell you. And in other words, they cannot predict heart attack and stroke. We'll talk a little bit later with Dr. Goulder about his transition from doing things like stress tests and angiography, taking folks to the cath lab, to doing more things like CIMT, things that in many ways have a little bit better predictive value. And that's what the book's about. That's some of what we'll talk about today. But before we do, let's just do that brief one or two slide deck on stress in that stress series. What is stress? How do you define it? Well, it's broadly defined as environmental demands, internal demands, or both, which tax or exceed your adaptive resources in an individual, social system, or tissue system. That's a more academic definition. Other definitions may be practical, or the idea that something that you care about is about to change. And it can be good or bad. A marriage is stressful. Graduating and from college and getting a new job can be a major stressor. Clearly, a move to another town or even another house is a stressor. So one thing we do know is the consequences of prolonged stress include psychological and physical health effects. This is not a psychological channel. I don't have a gazillion tips on how to think about things differently. I tend to focus on the science and the medical science, but it is really clear. There's just no doubt in the medical science that those of us who, that stress has a significant impact on our health. It kills us early and it disables us early. So here's a quote. It's pervasive in today's society. Nearly a third of Americans rate their average stress levels as extreme, 8, 9, or 10, on a 10-point scale, where 10 corresponds to a great deal of stress. We got into this. We've had a couple of mini-series before on stress and its impact on health. We got into this based on some requests from subscribers recently. And a book. The book is by she's faculty at Stanford, I think, and she's written a couple of books. This one is called The Upside of Stress, 2015. In that book, it's a New York Times bestseller, and she talks about the fact that it's not just stress; it's the perception of stress. And speaking of science, this is one of the articles that she talks about. It was published in Health Psychology, 2012, and the title was, "Does the Perception That Stress Affects Your Health Matter? The Association of Health and Mortality." And what they did, it was the University of Wisconsin. They examined the relationship between stress, perception that stress affects your health, and health and mortality. They looked at, tens of thousands of folks. It was a lot of folks. They did a couple of surveys. The one survey was more of a standardized approach to, do you have things going on in your life that most of us would accept as stressful? Have you been married recently? Have you had a death of a loved one recently? Have you moved, etc.? Then they had a few more questions in that survey. And those questions were, do you think stress impacts your health? And they found some very interesting information. What they found was both impacted health. Having stress, scoring high on the objective stress components impacted your health. You died earlier if you had more stress in your life. But they also found that you died earlier if you were one of those people that said, yeah, and I think the stress impacts my health as well. And in fact, it wasn't additive. It was multiplicative, meaning 2 plus 3 doesn't equal 5, it equals 6, or 2 plus 2 or 2 plus 4 doesn't equal 6, it equals 8. A big impact if someone both had stress and was worried about it. So that's where she saw her opportunity, and that's a place where I see an opportunity as well. I don't think it's practical for all of us to assume we're going to get stress out of our life. but it is very practical to think about rethinking how we manage stress. I'll just leave that alone, and we will, what we'll do next is go over and talk a little bit with Doctors Goulder and McClatchie. I think Dr. Goulder is starting with some basics information about cardiovascular inflammation. Is that right?
Yeah.
Okay. Why don't you take it away?
So thanks, Ford. So by the way, I love the term recovered cardiologist. Maybe I should start there.
We'll get a chance to talk
about Goulder and I'm a recovered cardiologist. So here's the thing. I spent 35 years of my life doing standard of care cardiology. And, you know, standard of care cardiology is cardiology by the rules, handed down by the guidelines, handed down by the American Heart Association, American College of Cardiology. How do I treat everything? How do I treat high blood pressure? How do I treat diabetes, a stroke, congestive heart failure, rhythm problems, anything you can think of in cardiology, there's guidelines for it, hundreds of them. And that's what I did. And my problem was that, I mean, I've been doing this for 35 years, and yeah, there's new stuff that comes out all the time, and it's exciting, but I was sort of getting burned out a little bit of doing the same stuff over and over again. And it's not that I'm doing the same stuff, but I'm seeing the same people come back with a recurrent problem. So I see some lady come in with a heart attack, and we whisk her off to the cath lab and put a stent in. And, you know, we say, oh yeah, your blood pressure's up, your cholesterol's up, and we're going to treat that, and we'll put you on your baby aspirin. And darn if she doesn't come back in a few more years and she needs another stent. And then she needs another stent. And I mean, we would see this all the time. And I'm saying, you know, we're putting Band-Aids on 30,000 miles of arteries in our body. And I was getting tired of that. And I was getting tired of standard of care medicine where I was working for a hospital system like almost all cardiologists do now. And I was being asked when I first started there, and I worked in this one system for like 14 years. I was doing all my cardiology stuff in the morning and seeing people in the clinics in the afternoon. And I was seeing 10 or 12 people. And then it was 14, 16, 20, 24. And I get less and less time to spend with my patients. And on top of that, they start throwing the electronic medical record at you. And now you got to spend an extra 10 minutes checking boxes when you're done with seeing the patient. And so I was really getting burned out with that. And the way I switched over was Barb was introduced to the Oral Systemic Connection. She's a founding member of the American Association for Oral Systemic Health, which is an organization trying to bring dental teams and medical teams together to improve their patients' outcomes. And at that inaugural meeting, Doctors Brad Bale and Amy Deneen spoke, and she came back going, "Oh my gosh, this is so great! You know, this is right up your alley. You're going to love this." And she says, "We're going to go to one of these preceptors." And I said, "I don't want to go to some dental meeting." And she dragged me, and I came away from this, and I went back down to where I was working, and I had one partner at that time. The program was just growing, and I said, "Joe, in 30 years of medicine, this was the best meeting I've ever been to." And it was the best meeting because they were explaining the whole root cause approach to treating vascular disease, to preventing vascular disease. And I said, you know, and we were talking about, we should be doing this. You know, it took us a little while to get around to that, but we should be doing this because we've got, you know, most cardiologists or most preventive physicians, arterial prevention physicians, aren't lucky enough to have a dentist who understands the whole approach also. And so that's how we got into this and opened the Heart Attack and Stroke Prevention Center of Central Ohio, where we do it all there. I do my component and Barb does her component there at the same time. So it's pretty exciting.
So you had a short deck you wanted to present, and I think it would be great. There's a lot of core basic Bale-Deneen in there, and I think it would be helpful for the group to see some of that.
Sure.
I think what you have to do is you have to do a screen share.
I do. I got it. The window share, and let me get this button. Wait a second.
There you go.
I'm sorry. I'm back to here and so yeah, we do pretty much standard Bale-Deneen approach here, and so we know that the steps are obviously pretend you're a bird flying over this tree, and this tree is inflammation, and you're looking down and you're seeing this artery here that's totally normal, and now the arterial age is increasing with cholesterol and inflammation building up, and plaque developing and plaque rupturing causing an event. And we know if we look down further, it's the tree, that's the inflammation is driving it all, and underground are all these root causes. A lot of things that standard of care physicians don't look for. I mean, I think more and more doctors are now looking for lipoprotein little a, but it's not part of it should be part of the standard cholesterol panel, for goodness sakes. Airway, sleep, disorders, chronic inflammatory disorders like autoimmune things, Sjogren's and rheumatoid arthritis and lupus and that sort of thing. And I think probably, as you alluded to, the thing that most doctors don't understand is how common insulin resistance is. The CDC did a study about 3 years ago that said that, there's 330 million people in this country, and 28.5 million people have diabetes and they know it. But there's another 100 million people. 1/3 of the country is insulin resistant and doesn't know it. And that just smolders along for, 10 or 15 years before you finally come in with a heart attack. So this is a big driver of inflammation, your genetics and lifestyle and all those other things. And what we know is, and why Barb and I are working together, is because it's these three things that she takes care of, and I take care of the rest of it. So it's really, and if I do everything right and I don't have this component taken care of, I'm not going to I may not be able to get the inflammation under control and get the disease under control. And so, we know that it's arterial, it's inflammation that drives this whole process. It's the question is, are your arteries on fire? So if you look and see if they've got disease by doing the CIMT, and yes, they've got disease, and then you want to know, is there inflammation, which is going to drive the whole process, and then why do you have the inflammation? So it's pretty simple. So did you want to go on and talk about CIMT stuff, or did you want to talk about Barb's component, or?
Why don't we talk about Barb's component next? Then we'll get back to CIMT.
We'll go back to there.
All right, so welcome everybody. I'm a complete health dentist, meaning that I understand the health of the mouth and the health of the body are directly related. And so we know that gum disease, periodontal disease, is a chronic inflammation process. And this is a nice little diagram that just shows when you go to your dental hygiene visit and the hygienist uses a periodontal probe and starts checking the health of your gum tissue, you're hearing a lot of numbers, 1, 2s, and 3s, which are healthy measurements. That's millimeters. But you start hearing 4s, 5s, 6s, 7s, and you start hearing about bleeding. What we know is there is an imbalance of bacteria that's going on in your mouth and deep down in the pockets between your tooth and your gum. And so this is a visual that just shows that every time you hear that there's bleeding present in your mouth, that there are harmful bacteria that actually enter your bloodstream from your mouth and can affect the rest of your body. There are saliva tests that you can have done that actually identifies what type of bacteria. And we do know that the bacteria that lives deep down in the tissue and bone do not require air to live. And so they are the most destructive bacteria, and those are the harder to kill. So you'll have some periodontal therapy, and lots of times there are different modalities that we can use, whether we choose to do systemic antibiotics because you're at very high risk for cardiovascular disease, or there's oral probiotic care, or there's PeriProtect trays that actually forces oxygen down into the pockets of between the tooth and the gum to kill bacteria. But basically, periodontal disease is a medical condition with a dental solution. So that's the benefit of a dentist and a cardiologist or a physician medical provider working together to eliminate that source of chronic inflammation. And we have a 3D cone beam x-ray machine that we use for both practices, which will help identify sources of inflammation that a patient may not even realize they have trouble with. And so this is an example of somebody that's had treated root canals, have no problem with it, but yet we can see these abscesses at the root tips deep in the bone, and that can be full of dangerous bacteria as well that can go through your body and cause inflammation. You may not know it. So this 3D cone beam has a big enough view that we can see from the TMJ area, all the sinus area. We see lots of polyps and retention cysts in the sinuses. We can see these we saw the root tips for all the teeth to look for abscesses, whether they've been treated or untreated. And then we can also look down at the airway, which is a sample here, to see if they may be at risk for obstructive sleep apnea. You can see how narrow the airway is. And this is actually somebody standing up in the machine versus in bed when you're lying down on your back, where your tongue falls back and your jaw falls back. So we can get some initial volume measurements and go through a sleep screener. And we actually offer home sleep testing here at the practice to get an idea if you are suffering from any kind of sleep disorder breathing. The cone beam will also go down to the carotid artery area. So many times I'll take pictures, take a scan for an infected tooth, but may find that there's calcifications in the carotid artery. So I'll bring attention to my patient and go over the combination of health history, periodontal disease, any infection in the mouth, and say, you have cardiovascular disease. We can see that it's present with calcifications in your carotid artery. We do send all of our scans to be read by a radiologist, so they will have a sheet that comes back that will talk about the calcifications in the carotid artery. So this is a great opportunity where I can introduce this patient that seems to be at high risk for many things over to Eric so that we can co-manage them and come up with a treatment plan. This is just something that sleep disorder breathing really is in the dental arena. We tend to look and find challenges with patients that may be having sleep apnea that the standard of care physician may not notice. So scallops of the tongue, you can see on the lower right, there's indentations. And yes, it can be because they have a larger tongue. It could be that they have a very high palate and there's no place for their tongue to go. It can be that when they're breathing, their brain is saying, thrust your jaw forward because you're not getting air. And so a patient's jaw will go forward and their tongue will start pressing against the insides of the teeth. So that is a very red flag for a possibility of sleep disorder breathing. If we see a lot of wear on our patient's teeth, we will start asking questions about their breathing, because clenching and grinding as they're moving their jaw forward or tapping their teeth to wake themselves up to take a breath is a common finding. Acid reflux or GERD is another common finding for obstructive sleep apnea, as your diaphragm constricts to force your lungs to take a breath. We can see erosion on the teeth, as well as the patient complaining of heartburn. And again, narrow palate. So a lot of people that have had orthodontics, the old model is a lot of removal of bicuspid teeth to make things, close spaces and make things pretty. And in the long run, by taking out teeth and collapsing the arches, we're actually increasing the chance of obstructive sleep apnea. So those are things that an oral systemic dentist and hygienist will be looking for when you go to your dental visit. We have patients that, in fact, I had a patient that had rheumatoid arthritis diagnosed, and he was bedridden and just could hardly walk into my office. He was referred in by a biofeedback technician. And upon the evaluation of his mouth, he had 168 sites of bleeding in his mouth, and he actually had some suppuration or pus coming out of his mouth. And he did see a dentist within 12 months of before I saw him. And we saw on his scan that he had cardiovascular disease because he had calcifications in the carotid artery. Eric did a CIMT, which you're going to learn a little bit more about. We do know that he had soft plaque, and we did take a saliva test, and he had a lot of high-risk bacteria. So this particular gentleman had so much infection, inflammation, and was so high risk that the dentist, the cardiologist, and the hygienist all sat down to get a game plan of how we were going to treat this patient. And by having the ability to do a CMT and doing blood draws in our office, we were able to get some blood work before we did any dental treatment. And we found that the inflammation number, this HSCRP, that should be under 1 in this particular gentleman was 35. So after doing dental treatment, periodontal therapy, it went from 35 to 26 in 2 weeks. His hands were feeling better. He was starting to stand upright. In 3 months, it went down to 1.6. So he was amazed. He felt like he got his life back. His rheumatologist did not even entertain the thought when I tried to contact him and talking about objective testing that he would understand, because it was a medical objective test that many dentists don't have objective testing, but we could tell that with our dental therapy that we made strides in his oral and his systemic inflammation. So it's very gratifying and very life-changing when you can have a medical and dental provider work together.
I had a patient like that just this week. It was a patient that came in, had a C-reactive protein. I think it was like 6 or 7. And this patient didn't have rheumatoid arthritis. So as we know, rheumatoid in and of itself, rheumatoid arthritis is one of the classic inflammatory diseases. So it will drive that on its own. She didn't have that. She did have some significant oral problems going on. She had some procedures done. She had, evidently it worked. It had a big impact. Within just a few weeks, it got down to less than 2, and it's continuing to drop. So you can accomplish a whole lot with good oral hygiene.
It's amazing. I mean, with this patient that Barb was talking about, this gentleman was almost bedridden. And he was just in the office, I don't know, maybe a month ago, and I saw him and I said, "Hey, how you doing?" He said, he came they almost skipping down the hall. He was standing straight upright. And I said, "How much weight have you gained?" He said, "You gained 20 pounds. And I mean, it was like he was, emaciated before. He was, with chronic disease, and he's gained 20 pounds. He's up and about and helping his kids with the heart. He rode his motorcycle here. So, I mean, this is a guy, and I don't want to put down rheumatologists, but he was being seen by a fellow at the university. And the fellow said, going, I don't know why, and so Barb reached out to the attending and said, "Hey, look, here's this, and the attending didn't know anything about what was going on. I said, "What, here's what we did." And the attending goes, "And we didn't change any of his medicines?" Says, "No, you didn't change any of his medicines. I just took care of his mouth." And he now is, and this is a guy his rheumatoid arthritis was explosive. I mean, this is basically about a year's history of rheumatoid arthritis, going from being normal to being almost bedridden. And so, our bodies are amazing, but we've only got so many soldiers to fight the battles. And if you've got this going on and the rheumatoid arthritis, you can't take care of everything.
You bring up a good point. So we talked about insulin resistance and prediabetes, diabetes as the number one, population-wide, the number one cause of this problem. You quoted that CDC number of a third of us. The reality is JAMA has done some studies. UCLA has done some studies over the past couple of years that would indicate it's actually over half of us 30 years and older. And we all know that it increases. Age is, obesity, yes, is a major driver, but age is an even bigger driver. So if we're in our 50s and 60s, we really need to be afraid. We need to be very afraid. Make sure that we know exactly what our glucose metabolism, our carbohydrate metabolism is. And most of us don't know it.
And the problem is that I think that, and hopefully you'll agree with me, I think medicine's gotten very sloppy. Because, we don't do a simple glucose tolerance test anymore, right? Come in fasting, see what your blood sugar is, drink the sweet drink, and check your blood sugar at 1 and 2 hours and see how you're handling the sugar load. Doctors, they'll do a fasting blood sugar, they'll do a A1C, which is a great test for following diabetics, but it's a lousy test for diagnosing insulin resistance, right? And so instead of doing that, they'll just do the simple one blood stick thing and tell you you're fine. And they're missing a lot of 60% or more of the people with insulin resistance by doing that.
Even the endocrinologists have said, you know what, A1C is not a good way to diagnose it. Anything that impacts hemoglobin is going to impact A1C. Things like pregnancy, genetics, depending on which part of the world you're coming from and which genetic pool you're coming from. Kidney disease, liver disease, all these things can impact hemoglobin. And when they do, they impact A1C. So, yeah, you're right. In fact, I know that I actually learned doing OGTTs on people for this purpose from Brad and Amy. I've gone a little bit further, and I do what's called a Kraft insulin survey. Mm-hmm. So instead of just looking at our body's moving reaction to challenge with a glucose challenge for how much your glucose is changing in your blood, I also look at how much insulin is being required to manage your blood glucose. Very, very interesting thing. What I'll find is about 20% of folks where I would have scratched my head in the past and said, you've got plaque, you don't have other causes, you clearly look like you've got some insulin resistance, but your numbers are not really that bad. Well, then I'll go back and find that it's taking twice, 3, 10, 12 times the amount of insulin that it should to manage their glucose. So it adds a significant amount to just start looking at insulin as well.
And so I've just, Barb and I have been doing this for about 4 years now, and I'm just starting to sort of say, yeah, maybe I should be looking at the HOMA IR too. So I've been doing that a lot more because, there's a lot of people that it doesn't show up on with their fasting blood sugar or their routine fasting blood sugar and stuff. So I'm doing insulins and HOMA IRs on people more frequently now too.
I haven't had as much, to me, HOMA IR has been fairly deceptive, again, because most of the HOMA IR values that I've seen are a static value. And it's sort of like, getting a static picture is sort of like getting a picture of me standing out smiling in the street, but we don't know that a bus is getting ready to run over me. So, and very similar analogy to watching we have to watch, as you mentioned earlier, a challenge. How does our body manage that challenge?
Right.
Speaking of challenges in life, I gave you a little challenge early on about recovered cardiologists. You smiled and have already mentioned you like that analogy. I think you've covered it pretty well already, that your typical cardiologist has a very different perspective on what we're doing. The typical cardiologist is busy doing a lot of other stuff and sometimes doesn't have the time to focus on the root cause, doesn't have, has other stuff on his or her plate.
Right.
One thing we haven't covered yet, though, is the CIMT. And you learned with Todd. You went to the school of Todd and cardio risk to learn how to do this. I went to that school and flunked out. I spent several weeks diddling around with that thing. I got the equipment. I brought it home. I just started thinking, this is hard. I know I can learn it. But here's the thing. Is it the best? I was just getting that practice started it was a Bale-Deneen practice at that time. And I needed to be seeing patients. We had folks nearby who were just excellent. And I just gave up. I sent the equipment back and I said, Todd, I have immense respect for you and what you're doing. And Eric, I have immense respect for your stick-to-itiveness on learning that. I think it would be very helpful. One of the things that I find with patients that come into me is a lot of them come in with a CIMT already done. Many of these CIMTs don't even have any statement. I mean, it's clear. Well, the most common thing I'll see is I'm just getting a flow study. There's nothing about exactly how much plaque is going on.
Right.
Those that have obvious plaque in there often still don't even tell me whether it's soft plaque or stable plaque.
Right.
So you and I both know a little bit more about what you tend to see in the community versus what Todd is teaching folks to obtain. Maybe you can give us a little bit more detail on that.
Sure. So, the difference between the ultras, it's all the same equipment. Okay. It's just what you're looking at. So the difference between what we do with a CIMT and what standard of care does when they do a carotid Doppler is they're looking at the blood flow through the artery. That's all if they see plaque, they may comment on it, but basically they're going to say, the flow's normal or not normal. And we know that the flow's not going to start to decrease until it's 65 to 70% blocked. On top of which, when you're calculating the flow, you're looking at, you want your transducer to be as parallel to the flow as possible, right? To see if you're gonna, so if a bullet's going this way, you want to measure the velocity. You want to be right here looking at the velocity coming at you, or looking at the velocity going away from you. And when we do a carotid CIMT, we're almost perpendicular to it. So there's a calculation when you're doing the flow, an angle theta, that is the difference between what the artery is going, the direction the artery is going, and where the transducer is coming in. And so it's really, I don't think it's a terribly reliable test. I mean, yeah, I can tell you if you've got severe blockage and and you're having symptoms and you need your carotid cleaned out. But I can't tell you if you've got, what they can't tell you, and what we do differently with the CIMT is they can't tell you how thick the lining is. Is it thicker than it should be? Do you have cholesterol and inflammation starting to build up? Do you have an arterial age of, Barb, when she had her first CIMT done, she was 55 years old. Her arterial age was 83. She's got at least probably more, probably ever going back to Adam and Eve. She's got arterial disease in her family. And so she had it done 5 years later again, and her arterial age was 74, and she just turned, you don't mind, do you?
Oh, sure. Throw me under the bus.
She just turned 65 and just had her CIMT done. We did a CIMT day up at a friend's colleague's place up in Chicago. And she had her CIMT done there. And because the tech was there, could do it. I mean, I could have done it too, but we didn't. But her arterial age was 66. So she's gone from 28 years older to normal in 10 years. And that's amazing. I mean, clearly we can reverse this process. This is not what we learned in medical school, which is the blockage gets bad and then it gets worse and worse and worse and finally closes. That's not what happens. You know that. It's the mild blockage that cause the problem.
So soft plaque.
So what we're looking at is the arterial age, and we're looking from 3 different angles on both sides. So we've got 6 views of the artery where we're going to measure the arterial age. So it's a very reliable number. And it gets thicker as we get older, but it shouldn't do what Barb's did, get that thick. So we can compare that and say, and then the real advantage of the CIMT is we can do it as a baseline and come back a year later and say, hey, things are getting better. This plaque this arterial age is getting better. It's getting younger. We're reversing the process. Or you've got plaque and you had 1.6 millimeters of plaque and it was heterogeneous, but now there's more calcification. It's stabilizing and it's shrinking down a little bit. So it's a great test to follow our patients, and it's sort of a grade card that says, yeah, we're going down the right pathway.
Barb, you're a poster child as well. I'm a poster child for that. You don't see that level of reversal that often. When I had my first, when I was in my mid 50s, and my arterial age was mid 70s, and it wasn't like I didn't know prevention. I taught this at Hopkins 30 years ago and have continued to practice it. But there were some tweaks I needed to make. Mine was a dramatic change. I slowed down on my carbs. I agreed to go ahead and start taking a low dose statin, which I'd been putting off. And within 18 months, I was down to the low 50s. And you would think, well, a lot of that had to be just some variation. What was very interesting was, given what I was doing at that time, running a Baldwin type practice, I was getting people were getting CIMTs every month or so. I was having a tech in. So I'd just hop up on the table and you saw a very smooth curve where it just reliable test after reliable test where my numbers were dropping. Now, Eric, given what you've done, given some of your background and some of what I've studied more recently, I think both of us may say, a lot of that is the inflammation itself. It's the liquid that's building up in that plaque. It's where those macrocytes, those monocytes, those leukocytes are releasing what we call cytokines, things that pull in more immune cells, release enzymes to try to dissolve that plaque. Well, I don't think we really pull out a whole lot of that old LDL, that cholesterol. What I think we really are doing with you and me, Barb, when we demonstrated that huge decrease, I think we were getting rid of a lot of fluid, a lot of inflammatory cells. But that may be a discussion for a later time. We've covered a lot of information. There's a lot more we could cover, but it's getting on into the show. And I usually each week will go ahead and respond to questions. We've already responded to one of the questions, which we'll see in a few minutes. Somebody's already asked, can you ask your guests if they've ever reversed somebody's plaque? So there you go.
Yeah, we do.
So Gilbert, will you give us the water ball and we'll go into the Q&A. So there we go. Bart Robinson, good morning, Doc. Enjoying reading your book so far and have recommended to several people. Thank you so much, Bart. I appreciate it. Steve Mitchum, most important channel on YouTube. A couple of very nice comments. Thank you, guys. Southern Grandma, good morning, y'all. Good morning to you, too, as well. Steve, I agree 100%. Now, Love Mechanics. Has PrevMed cut out that ridiculous pill that made him hack up a lung? so here's where that comes from. Eric, you'll recognize this. I don't know if you will, Barb, or not. I have hypertension, and I have been taking an ACE inhibitor. And I do have some pretty bad seasonal allergies. I got a lot of that from my mom. And during those seasons, it is what it is. I've got a responsibility to give some presentations. So quite often I'll get a combination of that seasonal allergy, ACE inhibitor hack, and I'm still hacking while I'm trying to give a presentation. So I know it's ugly sometimes.
It's funny for it. I mean, that's a really important medication that we use. I don't use a whole lot of medications, right? I may prescribe one or two, prescription medications for my patients, but I was fine. I mean, my blood pressure always ran around 120, 124 over 65. And I had a knee arthroscopy done and had a physical right before that. And I was 120 over 60. And then I'm in Barb's dental chair a year later, and she checks my blood pressure. And I'm 170 over 90. And, and you know, I'm feeling fine, right? And
I'm not going to tell a cardiologist he has high blood pressure.
Yes, she did. But she was using that ridiculous wrist thing, you know, like back there, put her arm. And I said, that's a fun. Check it again. It was still 170. I said, I don't believe that. I was living 2 hours away. I'm going to check it for the next, 2 weeks at home. And I checked it 2 nights at home when it was 170 over 90. And I said, okay, fine. I now have what my dad had and all 4 of his sisters had. I've got hypertensive cardiovascular disease. And so I put myself on what? An ACE inhibitor. And
right.
Like 2 months later, Barb's going, why are you always coughing at night? And I go,
so mechanics, there's a reason why Eric and I and a lot of other people use ACE inhibitors. It's similar to a reason why a lot of us will use low-dose statins. And a lot of us learned that from Brad and Amy, that they have things called pleiotropic impact. Pleo meaning many, the Pleiades, that's the 7 sisters. Pleo means many and trophic means going after. So a pleiotropic mechanism is a mechanism that's in addition to what is obvious. So everybody, almost everybody in the medical world thinks of statins as being for LDL. Almost everybody thinks of ACE inhibitors as being for blood pressure. But here's the thing. If you look deeply at the research, love mechanics, you'll find that both of those medications decrease cardiovascular inflammation, which most of us on this side of the cameras here are very convinced is the real cause of immediate cardiovascular risk. And not only do low-dose statins and ACE inhibitors decrease that cardiovascular inflammation, like we talked about earlier with stress, there's not an additive effect, there's a multiplicative effect. So I'll actually even look for an excuse. If anybody gets just the least bit over 120 over 80, I'll have this discussion with them and suggest that we take they consider at least a low dose ACE inhibitor. Scott Nicholson, hi from Belfast, Northern Ireland. I don't think we've ever had anybody from Belfast. Great, thanks for letting us know where you're coming from. Doc, you've mentioned it's not uncommon for a patient to get a higher calcium score on the second test after making the lifestyle changes. Can you elaborate more on this? I could, but I see Eric over there nodding his head. You want to take a shot at that, Eric?
Well, so, why I don't use, I will often get a coronary calcium score on my patients just to get them for a baseline. Do you have obvious disease going on in your coronaries? But I don't usually use it to follow the patients, because if, say, I've got a coronary calcium score of 200 today, and I get it done in a few years and it's 300, I don't know if that means I'm getting more disease or I've all of a sudden got religion. Now I'm doing everything right and I'm calcifying and stabilizing the soft stuff that was in there that the coronary calcium score doesn't pick up. So I don't really put much stock in an increasing coronary calcium score. And I know that Brad's coronary calcium score is way up there. He's got a bad family history of arterial disease. And I've never checked mine. I know I've got arterial disease. I saw my dad's heart catheterization before he passed away. So I know I'm going to have it. But the good news is, when I had my first CIMT done, I had a little calcified plaque over here on the right. That didn't bother me too much because I'd been on a statin for 15 years. But when they did my left side, I had about a 25% plaque over here that was mostly soft. And I'm going, what the heck? It's like deer in the headlights and I'm going to die just like Dad did. And I said, wait, we can fix this. And the problem was Mom and Dad, thank you very much, gave me a boatload of LP little a. So without knowing about LP little a, I'm treating my LDL. And that's what I was doing, was treating my LDL, not the inflammation, but unfortunately I was treating some of the inflammation as well for 15 years. But then I needed to work on the LP little a too. So now this is a rock pile and I'm good. But yeah, it's not a very good test to follow the arterial disease process.
But a great story, and you do the same thing I do. You go down some bunny holes,
Oh, yeah.
and I keep apologizing for it. I'm going to quit apologizing someday, because when I do, the viewers say, the bunny holes are the best part. That'd be a little late. So Vagabond, just one more repetition. Calcium score measures calcium. It does not measure soft plaque. Soft plaque is what causes the real risk. And once you have soft plaque, the goal is to stabilize it. When you stabilize it, you end up calcifying it. Nana 820 Abel. So periodontal disease can cause calcification of the carotid arteries of the neck. One of you want to take a shot at that?
I believe that 50% of heart attacks and strokes are triggered by oral pathogens, which is an amazing statistic. So we do know the correlation of the inflammation driven by periodontal disease does affect the lining and how the lining responds to this bacteria and the plaque. But as far as the calcification, I have to yield to you. I'm not aware of calcification.
Indirectly, I suppose, since it's a root cause, periodontal disease is a root cause, it can help drive arterial disease, but it's not the periodontal disease that's actually causing the calcification in the arteries. She's just, when she does that cone beam, she serendipitously finds calcification in the arteries and says, hey, by the way, did you know you've got arterial disease as well?
This actually brings up some of the discussion we were having before we started about, what's the biggest issue? Does, Brad and Amy will often talk about how periodontal disease actually causes cardiovascular disease, and they make a good case for it. They have their own article with Dave Vigorist where they talk about that. They often quote the article that you just quoted, Barb, where they actually went in and looked at the clots that caused heart attacks and found them, they cultured them and found them being, they had the same bacteria that people had. Some of those anaerobes, for example, that you're talking about in those deep pockets.
And those anaerobes are root plane resistant, which is why on high risk patients that we really like to hit them with a antibiotic while it's becoming systemic, hit them hard once so that we can kill those bacteria. Because if you're just using an ultrasonic and breaking up the biofilm, if you're not killing them, it's just almost creating more colonies of the anaerobes in the biome. So we like to use both periprotect trays with the oxygen to kill the anaerobes, as well as systemic antibiotic if they're high risk.
I tend to approach it from a slightly different perspective. You can see some of these CDC headlines and places where they've, especially more 10 years ago, you don't see them as much anymore, where they talked about gum disease causing heart disease. One of the things that we tend to miss in this whole debate is, guess what? Guess what the number one cause of gum disease is? Prediabetes and diabetes. So we've got again, well-hidden Jack the Ripper following most of us, and we just don't know it. It's causing oral health problems. It's causing cardiovascular disease. And to Brad and Amy's point, once you start getting there, clearly there's evidence that the continued problem with oral health will continue to send you even further down that cardiovascular hole. So very good point, Nano Toolable, 8 Toolable. Jonathan Hull, good morning, Dr. B. Question for the visitors. Do you have patients who've reversed their arterial plaque? What were the significant lifestyle changes that they made? So as we discussed, not only patients, but you yourselves have done it.
Yeah, so it's, that's one of the reasons that we do some genetic testing, because, one of the biggest lifestyle changes we make on our patients is diet. And we need to know a couple things about your genes. Do you have mutations in the haptoglobin gene? Do you have mutations in the ApoE gene? And that's going to change what diet we're going to give you. We're going to recommend to you. And then, as I'm sure you've talked about on previous shows, the importance of if you've got diabetes and haptoglobin 2, about being on vitamin E and lowering it. But lifestyle takes care of 85% of what I do. And I say, I don't mean to belittle, say that, well, I'm not being real, I'm just telling you to eat right and exercise, really. And, but most people don't do it, right? So we really have to spend some time with our patients explaining the importance of the lifestyle changes.
You can't out-prescribe, you can't out-stent, you can't out-bypass.
We've got a dental hygienist here in the office, and she says you can't outrun a cheeseburger.
Vagabond Sojourner, excellent video, important information. Another pillar to address for optimal health. Thank you, Vagabond. Bill H., great episode. And Bill wants to know where you're located. Tell us a little bit more about that.
We're in Worthington, which is a suburb of Columbus, Ohio, right in the center of the state. Home of the Buckeyes.
OH.
There you go. Buckeye territory.
Yeah.
Vagabond, great to hear a proper CIMT can show progress. Very encouraging. Planning on getting a CIMT this fall.
And one of the things that most places, even if you go to a hospital or a lot of places that do CIMTs don't do, is what Todd stresses is you've got to do it the same way every time. So you're trying to get, there may be a little variation. You may not be perfect, but if you measure here, you measure here, you measure here, you're going to get, that's how you get that smooth curve that says, yes, your arterial age is coming down. So we were measuring, looking at the same, we're comparing apples and apples, right?
Very true. Very true. So Carrie or Care says, what nature supplement to take for blood pressure? You get into supplements very much, either of you?
We do. And, for blood pressure, obviously beets are really good for you. And that sort of helps raise your nitric oxide.
Yeah.
But other than that, the main thing that I do for blood pressure with lifestyle is if I can get my patients to lose weight, it's amazing, right?
Yeah, same here. We've, especially over the past few years, I've gotten deeper into supplements and have done a lot of work in terms of just looking at the science. And clearly, you see major impact from niacin, especially for somebody like yourself with Lp(a). Vitamin D3 has become a big issue, especially over the past couple of years. I think those are two of the most important, but there are others as well, and just not quite as many for blood pressure. I would agree with you. Nitric oxide is the big one. You can get that from beets mostly. One of the problems with the dietary things, you got to be careful that you're not getting sugar beets and getting a whole bunch of carbs, especially if you can't metabolize those.
Like trying to fix your potassium by eating bananas all day long, right?
Right.
And getting a sleep test. That drives blood pressure quite a bit. So, there are other avenues that could be triggering that blood pressure.
I agree with you. Weight loss, sleep disordered breathing, a couple of the really critical things. I thought this was crazy. One of the groups that makes it's a machine that helps you do some coaching on your breathing. And I thought, I know breathing has a little something, but then I looked, it was FDA approved for blood pressure management and it was AHA recommended. So I said, you know what? Okay, let me take a look. I did. And I was getting like 10-point drops in diastolic, 15 and 20-point drops in systolic. Now you automatically assume, oh, this is not going to last. Well, it doesn't last if you don't keep doing it, but you get to it's amazing what you can accomplish with slowing your breathing down, increasing your expiratory phase. You look at, you hear about that, you think, well, can we do that? That's part of just managing stress and meditation, things like that. The actual research doesn't support meditation quite as much. It does, but not quite as strongly as using some sort of biofeedback type of machine to measure your own breathing rate, going from the normal 20 down to half that, 10 or less, and big increases in expiratory phase.
Before it, I also think with COVID and all the masks, I think there's an increased mouth breathing. Just getting used to breathing through the mouth because of the nose. And, of course, that changes the environment of the mouth as well with anaerobes. But I find myself breathing through my mouth more than I ever have before. And I think it's a result of just the whole COVID transition and wearing masks. I have to stop myself because then you're losing your nitric oxide as well.
And talking about breathing, there was an article I just saw, I forget where I saw it, talk about high resistance breathing. So they're making people breathe through a narrow tube, and that lowers blood pressure. And you don't have to do it for 5 minutes. I can find the article for you. I've got it here somewhere. But, anyway.
It's amazing. We think of breathing as something we just know how to do. Maybe not. Maybe there's a little bit more than we thought once you start studying it. So Carrie goes on to talk about olive leaf, magnesium, potassium, flaxseed oil. 1957, Cato, good morning. Scott Nicholson, our medical community here in Northern Ireland could learn a lot from this. Thank you, Scott. There's virtually no crossover between dentists and PCPs here. Does low vitamin D have an impact on plaque buildup? And I would just comment, yes, it does in several different ways. Vitamin D has been implicated in insulin resistance. It's been implicated in immune issues and inflammation. If either of you want to comment about vitamin D, feel free.
No, there was just that one study that I'm sure you're familiar with, looking at men who had vitamin D's under 15 versus over 30, doubled the heart attack rate.
Right.
So, yeah, it's important, obviously.
Brendan Lenane, so-called normal hemoglobin A1C levels should be much lower. No question. Thank you so much. It's a great point. Once my patients start getting over the low fives, I start getting worried. You just mid fives. And again, you start thinking about the fact that it's not just the A1C, it's the hemoglobin as well. Carrie, oh yeah, I do try beet juice. Okay, well, good for you. Glad to hear it. And, there are ways you can get beets without the sugar in them too. I mean, a lot of beets don't have a lot of sugar. And there are a lot of over-the-counter supplements which provide you the same stuff that you find in beets. Otis Page, 75% blocked carotid artery. Do you recommend getting the surgery and trying diet? I think there's a lot more I would need to know. One of the biggest things I need to know, Otis, is that plaque soft or is it calcified? I also want to know if you're having symptoms. The biggest thing always gets back to what's going on right now. Do you have diabetes and you don't know it, or significant prediabetes and you don't know it? So in other words, are you spending hours every day with your blood sugar at 160, 180, 250, like many of my patients before they came to see me? Those are all critical pieces of the puzzle. Kay King, how about cleaning out your arteries with niacin and EDTA? So EDTA is a common, what's the word I'm thinking?
Chelating agent.
Yeah, chelating agent. And you saw a couple of blips in the science that chelating agents might actually help. I think part of the original concept might be, chelating agent will bring calcium in the arteries is associated with risk. So therefore, let's get the calcium out and use a chelating agent. The preponderance of the evidence really does not support that. And you can see why once you begin to understand that it's diabetes, prediabetes, insulin resistance, having an inflammatory disease like rheumatoid arthritis, consistently attacking, having oral health problems where you're consistently getting an infusion of bad bugs into your bloodstream. If you don't stop those root causes, you're not going to accomplish anything.
And, Ford, what I tell my patients often is that we can all live with atherosclerosis, with arterial disease. We just can't live with soft inflamed plaque, right? So I don't care if, like, for my own carotid up here, I've got a 25% blockage. I don't care because it's all calcified. And if I calcify this guy, I'm calcifying all these guys in my coronaries, and I'm good.
Education is power. Just the testing and knowing where you stand, and then it gives you that starting point. And it ends up being a game because you start chasing your numbers, and you just want to make sure that you're doing better. And it's just, education is just power.
Thank you very much. Bunny Bubs, will this be available on replay? It absolutely will. And we will take actually sections of it because not everybody wants to go in and watch an hour-long YouTube. So we take different sections and we make those available as well. What beet juice powder is recommended? Brand and place of purchase? I don't have a brand.
I've gotten them at Whole Foods before.
Beets.
Well, no, I've gotten the powder as well, but I grow my own beets. So.
Most of the powders don't have carbs. The supplement pills don't have carbs in them, and a lot of the juices don't. You just gotta look. K King, people on ventilators and will breathe better if they are on a low carb diet. No comment there. Supernova 1976. Arugula leaves are rich beneficial nitrates and polyphenols, better than beetroot. I didn't know that. Okay. Bunny Bubs, D3, should it be taken with K2 if prone to kidney stones? There's a whole bunch of stuff about K2. I've got about maybe a dozen total videos on K2. I didn't know that much about it until a couple of subscribers started asking me about it. So I did a lot of research. Just a quick point, K2, a lot of people think that K2 removes calcium from plaque in the arteries. So they recommend it just to do that. Once they start thinking about that, they start saying, well, vitamin D3 has an impact on calcium and you should take them together. You'll even find a lot of supplements where they have D3 and K2 given together. The more I look at the science, the more I think that K2 may actually have an impact, but I don't think it's what we all think. I think it may be another pleiotropic mechanism because when you start looking at it, it's very much associated with insulin resistance. And there have actually been clinical trials where they took middle-aged men and gave them like 400 microgram doses of K2 and saw a reversal of their insulin resistance. So I think it's a little bit more complicated story than most of us think. Bunny Bubs, kidney stones, breast calcifications, cataracts, pre-os. What helps and hurts? I don't know that we're going to have time to get into that unless one of you wants to make a comment.
No comment. I'm a cardiologist.
We did a series on osteoporosis as well. We actually did a couple of videos on breast calcifications, breast nodules. On the osteoporosis point, it's just like everything else. You got lifestyle, and then you've got medications. Lifestyle has to do more with exercise, weight-bearing types of exercise, and especially young before you hit menopause. Men get osteoporosis just like women, but not nearly as often. There are medications. The bisphosphonates are, a lot of people are afraid of them. Once that fear started creeping, it's like you see so many times in the modern world. Once that fear started creeping into the social media, the use of these drugs started dropping. Right after that, the numbers of problems associated with osteoporosis started going right back up. We were starting to deal with it, and then we hit the fear, and then there was a problem. Are there supplements? Yes, there are actually some supplements that are given for that as well. One of those being very high dose K2. Bunny Bubs, thank you for your reply. Supernova, would you recommend avoiding fats for ApoE genetic? that's a tough issue. You know, that's the standard science that you would hear clearly up till about 5 years ago, maybe 3 or 4 years ago. As you start getting deeper into that whole ApoE question and the dietary question, and you start thinking about carbs, here's the problem. You have so many people that have a carb metabolism problem driving this issue. And then you have people that also have ApoE 4. And so then you start getting into a question on how to deal with that. Those patients are a little bit challenging. One of the things that I've noticed, though, is that after patients begin to wrap their head around the fear on this issue and start looking at it, they are able to stay in a mildly ketotic mode and not just, overdose on fats, which what people tended to do with ApoE4 in the past. K. King, inability to process oil fat increases insulin resistance, avoid oils and fats. I would take another position on that, King. Nutrinuva, how you doing? L-citrulline for blood pressure. Yes, it's a good point. Thank you. And L-citrulline, like carnitine and a couple of others, are probably associated with a common mechanism of nitric oxide. Thank you. That's Daniel Trevor, for those of you who don't know. Garlic too. Yep, garlic has some impact. 57 Cato, I catch you late today, but does vitamin D, is it related to insulin resistance? There's clearly significant scientific evidence that it is related to insulin resistance. It's not conclusive yet, but there's significant evidence. Does the vagus nerve affect the heart, or can it lead to heart damage at the beginning of troponin? I will tell you this. We talked about the impact of slowing your breathing, of managing your breathing on blood pressure. That is mostly managed because of different impacts to the vagus nerve. The vagus nerve can lower our blood pressure, clearly lower our heart rate. Can it lead to damage at in the beginning of troponin? I don't really have a comment about that, Eric. Maybe you do.
I don't think so. I mean, the only time you're going to get troponin elevation is if you got some sort of disease process going on with arterial disease or something like that. The vagus nerve is, it's just going to help you slow down the heart rate.
Yep. Same here. Bonnie Bob says, thank you. Kidney stones, avoid oxalates, and drinking lemon water helps. We got another, I think he was concerned about that vagus nerve, Zivuya. Hopefully we dealt with it. Lemon water dissolves KS. My goodness, we've got just a few more. We'll get through those. Terry O'Rourke, what does your guest say about fluoride-free probiotic toothpaste? Barb?
We use oral probiotics a lot in our practice. It helps. It competes for the space for the good and the bad bacteria, similar to gut probiotics. We use, you don't need the fluoride. What you're really trying to do is alter the biome of the oral bacteria. So, what causes decay are the strep mutans and the sugars. So if you're keeping your strep mutans in check, you don't need the fluoride.
So one of the probiotics that we use has a mutation of strep mutans in it called strep rattus, and it crowds out the strep mutans. It sticks to the teeth just like strep mutans does, but it does not produce the lactic acid that chews holes in your teeth.
Which one is that? That's
Probiora Pro.
Mm-hmm.
Very interesting. I've not heard of that one yet.
It's also got two other bacteria there that
Radisaurus.
two other strep bacteria in there that produce hydrogen peroxide. So they're going to help kill those.
Very interesting.
Yeah.
Right before you go to bed is when we ask them to suck on the oral probiotic.
So Farouk Farr has commented a lot. He's in the Middle East. He had commented a lot on what he was seeing with COVID when that came up. The good doctor said lifestyle. Thanks, Dr. B. Drinking gravel root and prevent stones from forming. Huge exercise, vegetarian, doctor being prone to all these calcifications. I'm concerned. Castor oil, packs. Thanks for all the advice, Kara King and Zabuya. Bart Robinson, I've read some studies that say high intense vigorous exercise helps turn soft plaque into stable calcified plaque, hence a higher score. Yeah, when you go back and you look at the science around exercise, it's really clear that number one, having 2 or 3 good sessions per week helps. Very intense sessions. Daily mild aerobics like walking is very, very helpful. Resistance training is very, very helpful. We used to think it was all just aerobics. No, that's not the case. And then you start thinking about it and realizing, you know what? It's been shown that we all know. I mean, all you have to do is wear a Freestyle Libre and see, okay, I'm going to take a carb vacation, or somebody slips some stealth carbs into my meal, and I start to spike on my glucose. I don't have to do much. I just go for a walk, and that spike just comes right back down. Now, what will happen is intense large muscle activities will bypass, have that insulin-like effect and bypass those ailing insulin receptors for up to 48 hours. That begins to help you understand why you see the things that you see, Bart, where the high intensity intervals can actually help and should be repeated at least 2 to 3 times per week. Let's go. We're almost done. I drink lemon water all day. I've read that intense exercise. Okay, we got that one. Fresh beets, organic juice, and powder. Cut out the carbs. Carbs. Lost weight.
Lobster's okay, but no crabs.
Drink gravel root tea. And blessings here. Good info. Thank you very much. Thank you, Carrie. Cold liquids triggered paroxysmal intense atrial fib during heavy running. I've shared on the channel and did a series of about 24 videos on atrial fib. I have paroxysmal atrial fib myself, and like what we were talking about with high blood pressure. I did not elect, by the way, to get I got up to the point where it was like over 20% of my time I was in fibrillation. I saw a cardiologist, electrophysiology guy, and he said, yeah, I think we ought to do the ablation. After reading more, I elected not to. I lost a few pounds, and it went away. And the other thing I did was manage my blood pressure a little bit better. And we know losing a little bit of weight, managing your blood pressure a little bit better, and managing that sleep apnea, all are big, big deals for atrial fib, paroxysmal.
A lot of people talk about when we're treating atrial fibrillation with medications is it's just a stopgap measure until you can get the lifestyle modifications in place so that you control the sleep apnea, control the weight, that sort of thing. And then the atrial fibrillation goes away. Yeah.
And one of the other things that helped discourage me on this was knowing the relapse rate, very, very common relapse rate, and also knowing that I have a double dose of 4Q25. Mm. But we see Eric and Barb nodding. For those of you who don't know, 4Q25 is a gene that we have discovered that helps move the muscle tissue of the heart along into conductive tissue. In other words, it helps put you at risk for atrial fibrillation. So very good last question that allowed me to go down that bunny hole. Thank you. Thank you so much, guys, for joining us today. Any last comments?
Lifestyle, and my other point is that we don't do CIMTs enough. Everybody ought to get one done at the age of 40 and just see where you are. Don't wait until you're 60 years old and your dad died at 62 to start getting interested in this stuff.
To me, yeah, it's like if we could get a CIMT and a Kraft insulin survey starting at age 40 or even earlier, and then depending on what we see, repeat it every 5 years, every year, we would be so much better off. It's like we would take a major chunk out of sudden death from heart attacks, strokes, disability. We would have such an impact.
Yeah.
But I'm not holding my breath till that happens.
Yeah, just hold your dental team at a higher standard. You know, if there's access to saliva testing, get an idea where you are, understand that, you know, you and your spouse will have very similar biome just from kissing. So if you're treating one part of the partner, make sure the other partner gets treated as well so that you don't cross-contaminate. And another whole conversation we didn't talk about was, you know, dental clearances before surgeries and making sure that your mouth is not contributing to the ability for your body to heal. So that's another association of artificial joints and the health of your mouth. So if you're even heading towards any type of joint replacement, be sure that your mouth is healthy.
So true. So thank you again so much for joining us, and thanks
Thank you.
to the folks on the other side of the camera for your interest.
Appreciate it.
Bye-bye.
Bye.